Good afternoon, everyone. Thank you for joining today's webinar presented by Guidehouse on managing your revenue cycle's response to COVID-19. Please note that all lines have been placed on mute to prevent any background noise. If you would like to ask a question, you may do so via the Q&A feature in your GoToWebinar dashboard, or you may use the raise your hand feature to ask your question via telephone. Once our speakers have concluded, we will compile the Q&A roster. Please also note that the call is being recorded and all materials will be made available and sent out as soon as possible. I will now turn the call over to Mr. Tim Kinney. Go ahead, Tim.
Thank you. Good afternoon, everyone. As Rebecca stated, my name is Tim Kinney. I'm a partner and lead our revenue cycle practice here at Guidehouse. First and foremost, thank you again for taking the time to join our webinar. We hope everyone is safe and healthy at this point as we progress into month 2 of COVID-19. As a reminder, we will send all material post-webinar, and then we've also set up a website that will direct you to where material will be readily available. This is our third webinar in the series related to managing your rev cycle through this COVID-19 challenge. And as a reminder, the intent is to provide tactical information that you guys on the phone and are living in the revenue cycle can use today, tomorrow, and in the near future. So our information is updated daily. We try our best to make sure we're putting the most current information forward, but we will obviously at the end take questions and get back to people as well. As a little bit of kind of a transition, the first webinar we did was related to funding and getting organized around the FEMA funding and some of the vehicles that were available to hospitals and health systems. The last one we did was more of a shift to the beginning of telehealth, as that was becoming more and more evident of a concern and a challenge, and also a solution for those of us in the rev cycle. And we were looking at, how we recover, how we restore, and how we operate in this new model. So quick agenda for today. We're going to build off that. We're going to talk about telehealth, digital, what's changed recently here in terms of kind of the operational side. And then we'll get into some detailed information for funding. So as you guys may or may not be aware, we have a team that's focused on the federal side and is able to get insight and tracking this on an hourly and daily basis. So we have some really up-to-date information. And then we'll get a report out from the ground from me and Stuart. And then we'll also spend some time on coding and billing update related to kind of the latest guidance and what we're seeing out there in the marketplace. A little bit of preview in the future. We hope to focus on kind of refilling the funnel in terms of revenue. We know it's going to be different than some of the solutions that revenue cycle leaders across the country are taking. So we will end it with a question and answer session and make sure if we're not able to answer it directly, we will get back to you guys as soon as possible. So with that said, I will turn it over to Subra, who's going to take us through the update related to telehealth landscape.
Excellent. Thanks, Tim. Next slide, please. Next slide. Good afternoon, everyone. As Tim said, we'll start here with the changes in regulation. As many of you probably know, the majority of services delivered to any Medicare beneficiary via telehealth are now reimbursable at full rates. And many of the commercial payers are following suit. And of course, the details vary depending on the state and depending on the payer. Many practice restrictions have been relaxed as well, including licensure requirements and select HIPAA enforcement. And providers may qualify, health systems may qualify for enhanced or extended telehealth related grants to cover technology costs. So we wanted to spend a good amount of time, as Tim said, in giving you the details on these grants. And I'll after the couple of introductory high-level slides, I'm going to ask my colleague to provide you with details on the 8 grants that we are tracking. Next slide. Quick overview on the changes in regulation. Medicare will reimburse over 80 additional telehealth services, and CMS will allow providers to treat patients in other states. From a state's perspective, they won't be required to submit an amendment to make Medicaid payments for telehealth services in the same manner as was required for identical in-person services. The Office for Civil Rights, OCR, will offer waivers for HIPAA violations, meaning that they have opened the door that in the short term, you could use tools like FaceTime and Skype to be able to deliver video visits. ASCs can take on certain services typically provided by hospitals, as well as they can partner with local health systems to provide hospital services or bill as hospitals during this period. DEA registered practitioners can issue prescriptions for controlled substances, and Substance Abuse and Mental Health Services Administration. And if you are a provider of mental health services, there is a grant that you should pay attention to when my colleague goes through it. But they can now disclose patient identifying information without consent, again, during this period. So that's a quick overview of some of the major changes in regulation. Next slide. Our view from a telehealth perspective is we're viewing this as a platform to drive access and growth. As you know, the concept of telehealth has existed for a long time. Technology has evolved as well, but a big barrier for this becoming a platform that's widely used was reimbursement. And our opinion is, while all of the restrictions have been relaxed during this period, post-COVID, as organizations are trying to recover, this is going to continue to be a platform, or will be a major platform to deliver low-cost services, the cost of care services. While there is no way to predict what regulations or how deeply regulations would be rolled back, we fully expect that with the consumers / patients getting more familiar and comfortable with this medium, providers getting comfortable with providing care through this medium, and many of the payers seeing this as a lower cost of care platform, this is here to stay. So I would encourage everyone on the call to pay attention to the next set of slides, where we're going to talk about the grants. If you have not applied for grants, this is a great time to make sure you get in line. The grants available are first come, first serve, and for a limited period of time. But you should be looking to, given that this is a platform that either if you have, that you need to industrialize, or if you don't have, you need to build. You want to take full advantage of this reimbursement period to stand up that platform and get paid for it to the extent. There are some limits to what an individual organization can get from a grants perspective, but that's something you might want to take advantage of. And from a long-term perspective, as I started to say, this is your business model, we think, is going to change. The mix of virtual care volume is going to be significantly higher than what it was pre-COVID, which obviously will require you to rethink strategy and adjust to the new business model. So that's something that we are encouraging our clients to think about, and or at least begin to think about as they go through this period. So with that, I'm going to ask my colleague Allison to walk us through the grant detail. Allison?
Thank you, Subra, and good afternoon, everyone. As Subra mentioned, I'm just going to go through a little bit more detail about the funding opportunities that we can experience right now as we go through ramping up a lot of the telehealth capabilities. One of the first big ones, I would say, is the Federal Communications Commission's COVID-19 telehealth program. That funding has $200 million in it, and each award recipient will receive up to $1 million. So you can submit eligible expenses up to $1 million, but no, they will not cover the cost more than that. So they will cover 100% of the costs, and as you see throughout some of these slides, that is not always the case in some of these funding opportunities. So that's really critical to be aware of as you go through these processes. This opportunity opened up April 13th, and essentially the FCC will be dispersing funds from April 13th until the public health emergency has been declared over, or the funding has been exhausted. So on a rolling basis, they will be handing out disbursements. And as of April 13th, the FCC has already issued about $7 million to 8 states or 8 healthcare systems that are in 8 states and 11 health systems. So they are already starting to get money out the door and to wall. And then it lists several eligibility criteria for those that want to submit applications. And really the costs for at least the FCC program cover medical devices, telecommunication services, and other types of information services. The second one is the FEMA Category B, and we're seeing some folks submitting applications to FEMA after expenses are not covered under the FCC. So as you look at these, you may be able to have some expenses covered by FEMA that are not covered by the FCC. So that has started. This one, there is, as you can see, they will cover about 75% of the cost. It's currently open. And really, this is an opportunity for you to recover costs associated with emergency medical care, medical sheltering, management, control, and reduction of immediate threats to public health. The USDA, Department of Agriculture, also has a open award opportunity, distance learning and telemedicine grant program funding. So I know this looks a little confusing, but they just had a first round of funding that was $72 million. They've now opened up a second round of funding of $25 million that came out of the CARES Act. And those awards will be between $50,000 and $500,000. But on top of that, those funds that have not been dispersed out of that first bucket, the $72 million, that will now be applied to the second round of funding. So that's a great opportunity, again, for if you're standing up some telemedicine opportunities. The funding, the matching requirement is you must be able to demonstrate 15 match of the amount that you are requesting. And the time frame for this second window is April through approximately mid-July. And really, they have a variety of criteria, but I would say, as you can see in the asterisk area, they really give special consideration for treatment and counseling service for opioid or other substance abuse disorders. So they have a variety of criteria where they will leverage points against based on your rurality, your economic need, and a few other criteria. So I just wanted to highlight that for those of you that might be seeking funding for behavioral health issues, that's an opportunity for you right there. Next slide, please. There's also another partnership with the Department of Agriculture and Tufts University, where they will be awarding up to approximately $5 million, and you can request up to about $1 million. And they do anticipate issuing approximately 8 grants. And really, this grant opportunity is focused towards exploring telehealth solutions that will support access to nutrition and breastfeeding support for WIC participants. WIC is also known as women, infant, and children. So they are looking to really promote and implement an online solution that will provide virtual support to mothers as well as underserved areas for nutrition. I highlighted the HRSA grant opportunity. This is one that has already been awarded, and they issued that funding I believe the week of March 24th. And you can go on the HRSA website and look to see what state was awarded how much and what health system. So if you're interested in learning about where that funding was distributed, you have a link there that you can access and view that information. There's also the HRSA Telehealth Network grant opportunity. This is looking to fund some telehealth-focused rural health research centers, really looking to evaluate tele-emergency services or tele-behavioral health services that would include substance abuse and other abuse disorders. So the award ceiling for that, as you can see, is about $950,000. The application process is currently open and will close the 1st of July. And next slide. So all of those funding opportunities that I just reviewed are really more of the short-term opportunities, but I also wanted to highlight for you some of the long-term opportunities that are coming down the road that could help you plan for future funding requests. One of those is the FCC Connected Care Pilot. That is another FCC program that is $100 million. They have declined to establish how many grants or how much fund disbursements they will be issuing and how much. This program will be over the course of 3 years, so I would say it's a true pilot. They really want to evaluate underserved communities that have chronic care conditions such as cancer, obesity, cardiorespiratory issues, as well as those communities that serve veterans. This one, there's also a limit on the cost. They will match 85% of the cost that you have requested for reimbursement for the funds. And so the last long-term opportunity, this for our Agency for Healthcare Research and Quality, this has yet to be issued, if you will. They've put a notice of intent out on the website, but there's $5 million there, and really wanting to evaluate topics that are related to innovation and challenges during the rapid expansion of telehealth during the COVID-19 time period. So if this is an area of interest, you can go to that website and continue to check the status and see when they announce. They do anticipate announcing or issuing the grant notice in early May with a submission due. So that covers all of the current funding opportunities that we see on our horizon. And then next slide, please. So I just wanted to quickly go over the FCC funding. That is something that is immediately, and we've had seen a lot of interest in getting access to those funds. And real quick, there are 3 steps that you need to take in order to just begin the application process. So if this is something that you are interested in getting access to funds, I recommend you look at those 3 steps. You can go on the FCC website. The link was provided to you in earlier slides. So once you complete those 3 steps, then you can begin the application process. So that wraps up the funding opportunities, and I believe, Ian, turn it over to you.
Well, thank you so much. So Ian Stewart, Managing Director on the consulting side, and I'm going to talk a little bit about my work. I'm an interim VP or Executive of Revenue Cycle for a hospital in Minnesota, and have been on the other 2 webinars. If you could go to the next slide, please. So a little bit of what's taken place in the last 2 weeks. I'll talk a little about the hypergrowth, kind of speeding up digital health for all specialties and locations. I've had about a 30-fold increase in telehealth visits. So we had almost none, and we're now doing about 40% of our pre-COVID-19 volume for all of our clinics. We're facility-based, and so we've had to continue to work with the payers, and each of them have a different set of rules to kind of build our grid out by specialty and by type of code and doc. But we've seen a tremendous growth in that area, as many systems have. Spent some time focusing on recouping or rebuilding visit volume. There's a hope that we can get to 60, 70, or 80% of our pre-COVID volumes. It incorporates a tremendous number of areas. It's access, it's calling back all the patients, it's acquiring patients on the web, it's getting them, booked and scheduled and linked to a physician that can do a visit remotely. And that is, as most folks have grown to understand, an entirely new process for most folks. Cash is king. I've probably had, if not daily, a couple of times a day, expectations that the revenue cycle will collect every single possible dollar that can be gotten, as cash has been burning through as volume has continued to drop. Next bullet, a little bit about kind of pressure test your system. I've stood it up so fast that I want to go back now and make sure that what we expect to be reimbursed is able to be reimbursed. So are all the processes from the front acquisition portion, contact center, call center, the pre-reg intake team, have they done the work that they're supposed to do so that the HIM and the coders and billers can get these things coded and billed correctly? Can the claims get out the door? And then ultimately, can you be paid? About half of our claims are stuck in edits, and we're still struggling a little bit to try to get those things out. So I'm trying to get a lot of energy around that. Focus on how to market and acquire patients from home. How do you get volume back when folks aren't necessarily calling you, but you have to reach them via the web? Something that's also come up, we've had a couple of that can't do telehealth due to the type of services that they do. So how do we open up those sites of care when everybody's at home? That's proven to be an interesting endeavor. And then a fair amount of planning for opening up the surgical sites and non-urgent services. So once the government opens us back up for business, what does that look like? How do you schedule it? Where do you spend your time? How do you shift processes and operations when that starts to take place? And then something I've talked about at length, creating super templates so that you will have all of the documentation required. We started to think about HIPAA and consent and other billing activities that can come through either the clinical work or through verbal conversations with these patients. It's kind of the Wild West today, but we know that will end. And how will you structure and prepare for that? And then on top of run the everyday business, ramp up digital health, try to get your volume back. We're all dealing with furloughs due to low volume, and then subsequent planning for re-ramp if and when that volume returns. So it is a tremendously complicated situation, and I feel for a lot of folks that have to plan on both sides of the equation. Next slide, please. The last couple of bullets that I would speak to today is really think about how to reimagine what your operations may look like going forward. This is an interesting and great opportunity for all these changes to be woven in and continue long term. And so not only do we have to deal with the current situation right in front of us, but start to think about what that will do from an organizational change perspective, and how can you benefit from it. And then not only just getting reimbursed for what we're doing today, because most payers are paying for just about everything today, but pivoting to long term and putting a sustainable plan in the next few weeks to the next year of how are we going to continue to be paid once the COVID changes and implemented activities actually become reality, and you have to put a full sustainable plan together to work with your payers, because we all know or believe that telemedicine and the way that we're doing this right now will be woven into the way of the future. We'll probably have a significant number of less office-based visits. And so how does that, how will that work into what it is that you're thinking about while you're worried about your current financial situation with the drop in volume? So that's all I have today. I'll leave one last bullet. What we know today will change tomorrow. That continues to be the constant theme, and one day it will normalize, but that day has not yet come. So I'm going to hand it off now to Sue to take over and give you some coding.
Okay, thank you, Ian. This is Tess, and today Sue and I are going to focus on if you could forward to the next slide, please. Thank you. So we're going to focus on some of these other technology-enabled services that may have gotten overshadowed in some of the recent, scrutiny on telehealth. But these services are valid and billable, and like Ian mentioned earlier, I mean, it's imperative to capture every single possible dollar, and we think that there may be some opportunity, some missed opportunity, sitting right in some of these lesser discussed services. So when we say there's the confusion around what telehealth is, telemedicine, and all that, but I like to call it, it makes a little more sense for me when I break it down mentally into telehealth and other technology-enabled services. So all these services listed that you see listed in their original definition were meant to be performed, without a face-to-face visit. So they are always meant to be done in the virtual type world. So typically none of these codes, these services haven't had the drastic change that you've seen in other telehealth services that got captured in the expansions. So first off, you have that like an online digital E&M code. So what we want to, again, you don't want to, it's not considered telehealth. So the waivers that were made does not encompass these e-visits, the phone calls, or the virtual check-ins. Your e-visits, again, they should not be used for scheduling your appointments. It's really more of a less clinical type visit. It covers a 7-day period. They should be performed in a HIPAA compliant platform, which is your portal. To this date, I have not seen, I've heard hints that there may be some loosening of that, the portal type restriction. I haven't seen anything set in stone yet. If that happens, or if anyone on the call knows of that, please let me know. But that is one area that might get loosened. The e-visits are still patient-initiated visits, and you do want to remember to get that time documented in your note. The phone calls or the phone responses with the CPT codes there, your 99441s through 43s and your 98966 through 8 are not included in telehealth, again, because in their original description, they were done in a virtual setting. Now, what you want to make sure, the criteria here is that these should not have originated from an E&M service, a face-to-face service within the previous 7 days, nor should they lead to an E&M service within the next 24 hours or the soonest available appointment. So from a tracking standpoint, is it easy or difficult to capture that in a note? I don't really know, but those are the two key pieces that you want to make sure have been satisfied before billing these codes. And then your G2012, that virtual check-in, you want to make sure that in that, the documentation for those services, you have you're getting that patient identifier in there, detailing what transpired over the service. It has to be a minimum of 5 minutes in order to satisfy the criteria. And again, that same, it's not the subject, the issue covered is not tied to a face-to-face within 7 days, and that you're not going to be seeing this patient again within the next 24 hours or soonest available appointment. So those are just some of the criteria there. Next slide, please. So these, I want to take time to talk about these e-consultative services. One thing anyone with any familiarity in, in the coding sense is accustomed to services being between a provider and a patient, and the provider bills for their service. With these e-consultative services, this is in particular, it's provider to provider. And both of those providers can bill. If you meet the criteria, they both can generate a service. So what we want to look at here, just breaking down the two players. So you have a physician or other qualified provider who's involved in directly treating that patient, and they need the advice or opinion of another physician who has expertise in a different area. So that physician or non-physician practitioner would be able to bill on a 99452, which is basically a billing for the service, their request for that consultation. And then the other party involved would be that physician who is providing the consultative service. And that provider, depending, these are time-based codes, and we will cover the time parameters in a upcoming slide. There's a series of the 99466 through 49 is dependent upon the total time spent in this service. And one thing to keep in mind is that it is the time spent. You might not resolve the issue in one initial phone call. So if there is, a follow-up phone call or internet communication between providers, that time is cumulative. So you just want to make sure that you're capturing that, and then you would bill it once in a 7-day period. Next slide. Okay, so this just kind of breaks down in more detail some of the requirements that need to be met prior to reporting these services. We talked about making sure that your treating provider is, distinctly different from your consultative physician. So those are the distinctions. So in the guidelines, it specifically states the patient treating provider can be physician or NP or a PA. However, if you're the provider supplying the advice or opinion, that was designated as a physician only, the consulting physician. Again, I'm not exactly sure how this is one area they have not expanded upon, but depending on how extreme the situation gets during this, the public health crisis, they may do that, but at this point, I haven't seen it. If that review leads to a transfer of care, if the consulting physician had a face-to-face with that patient in the previous 14 days, or it leads to a face-to-face visit within the next 14, you would not be able to bill this service. So there are some criteria when you would not be able to report it, but I do think given the chaos, what's going on, there may be opportunities to capture some of these services. And continue. And this, I won't read this one flat out, but these are just the code, the coding, the CPT definitions, but you'll see the time parameters. So the minimum of 5 minutes, so a 5 to 10 minute discussion between physicians, you're already at that lowest threshold to report that 99446 code. So these are some opportunities that, I hope that if they're, available to you, that you're capturing that revenue appropriately. And next. So I'll pass this on to Sue, and she'll discuss some of the other coding guidelines.
Thank you, Tess. Now, this is just really more of a reminder for the folks that have joined us in the previous calls, but if this is your first call with us, we want to make sure that you're reporting the appropriate diagnosis for a confirmed COVID case, and that's the U07.1. And then, so you're going to want to be able to keep track of the patients that you're taking care of in your reporting, so that this is critical to make sure that these diagnosis codes are being used. Then we have some lab codes. And again, this is nothing new this week, but just a reminder that you can take swabs nasally or pharyngeal swabs. And if you do both of them on the same day, they are separately reportable. The data service goes back to 313 for these. The U001 and U002 go into effect on 2/4, or went into effect on 2/4. Next slide. So again, as Super mentioned, there's 80 additional codes in telehealth. We just want to make sure that you all know the different varieties of way that you can capture these types of services. We have the virtual check-ins, which are now allowed for new and established. We have our telephone services. And as an auditor and an educator, our whole philosophy has always been the phone was free, but now that's not the case in this period of time. So when physicians are calling their patients, we need to make sure that they have a mechanism in place to document those phone calls and to capture the time that they're spending. E-visits have now been extended for licensed clinical social workers, clinical psychologists, physical therapists, occupational therapists, speech language pathologists, so they can provide these G codes only. And it really must be established, the patient must be initiated and established patients only, although CMS said they're really not going to look back to make sure that it truly is an established patient. The letter of the law says it needs to be established. Remote patient monitoring is another opportunity. They removed some frequency levels on hospital visits, skilled nursing visits, critical care consults. The supervision requirements have been relaxed to incorporate virtual technology when it's appropriate. And then of course our waivers to kind of get past any kind of copays have also been put in place. Again, nothing new, but just a reminder for those, or maybe it is new if you're the first time joining us. Next slide. Oh, well, that is it for the coding period. If you guys have any specific questions, please let us know. If we can answer them right here live, we will. If they're very specific or unique to your organization, we will work to get back with you. So Tim, back to you.
Yeah, sure, great. Do we have any questions that came in over the course of the webinar?
We do. We have one question. Do we know if telehealth is going to be paid for on UB claims for hospital services such as therapy, cardiac rehab, or nutritional services? For our hospitalists, we bill on the UB and we aren't seeing information around this.
This is Ian. You know, we have, again, I probably repeat myself from the last a couple. We have payers that are allowing us to bill exactly as we billed before, and some have actually asked us to modify it. So I've recommended that folks reach out to their payers, to their contracting team, explain the type of activities and the billing as it exists today, and get their direct input to be done going forward.
Okay, another question just came in. How or when is Rev code 0780 used? We are a critical care provider base.
Sue or Tess, would you guys know that one, or is that one we have to get back to them on?
I would have to get back to you on that. I'm not familiar with the Rev code.
Okay, we'll take that one and make sure we follow up quickly.
There are no additional questions.
Okay, well, thank you very much. Again, as a reminder, we will send this material. We will follow up with a answer to the few questions we had there at the end and make sure we highlight those. Also a reminder, you can submit questions or ideas and concepts that you guys would like to hear about in future webinars at the guidehouse.com/revenue cycle COVID-19 website. So That way, we're trying to shape it and continue to evolve our discussions. Again, preliminarily, we'd like to focus on kind of revenue into the future, as we know that's top of line for everyone involved, and then the solutions to begin to backfill and again attempt to return to some type of normalcy. So again, we thank you for your time. We thank you for all the hard work that revenue cycle professionals are doing across the industry, and look forward to seeing you and hearing you on our next webinar next week. Thank you very much.
Thank you for joining today's call. Again, as a reminder, today's call was recorded. Please be on the lookout for a link to the recording in your inbox. You may now disconnect.